And of course, all this stuff, I feel like this is sort of a rudimentary version of, a lot of things that Julia talked about earlier today, and Rachel touched on some of this stuff too, but the comorbidities related to trauma, depression, alcohol and drug use or abuse, suicidal ideation, post-traumatic stress and other disorders. And just a very brief review of PTSD. I know Julia covered that earlier, but PTSD, the anxiety disorder that occurs following exposure to a traumatic event, it can actually cause neurobiological changes in the brain. Like Julia was talking about the increases in cortisol. There's actually, imaging of the brain before and after trauma, and so there's physiologic changes that occur in the brain because of trauma. And the symptoms occur in 3 clusters, and again, this is a review: a re-experiencing of the trauma, avoidance of usual activities, increased symptoms of arousal or hypervigilance. So what does that look like when the patient walks into your clinic? And again, a little bit of this same kind of thread. These patients often have a lot of somatic complaints. There is data that shows that patients with PTSD use healthcare services more often than patients without PTSD. They may make effort to avoid activities, places, and people that remind them of the trauma. So these might be patients that are the ones that are missing appointments, the no-shows, the showing up late. These patients might be the ones that when you see them, you kind of want to run the other way because they can make you feel really exasperated. They might seem very demanding. They might feel detachment, like Julia touched on this too, with a restricted range of affect, so they may have difficulty with relationships or a hard time connecting with other people. So these might be the ones that, it's difficult to form a rapport, and especially like in a fast-paced healthcare setting, you kind of have to be able to form rapport pretty quickly. So sometimes it can be more difficult. And they can have a physiologic and psychologic reaction when they are exposed to cues that remind them of what happened to them. And again, that's a review. But just consider of what that means when you're caring for a survivor of sexual assault. Think about what a GYN exam could mean or trigger for that patient. Like Rachel said, what does touch mean to them during the course of an exam, especially the touch that occurs, during a GYN exam, or even, during other parts of the exam too, not just the pelvic part of the exam. For instance, like when I'm doing a breast exam, sometimes I realize, oh, my other hand is touching their body someplace else. So I need to, tell myself I need to move that hand, or ask them, is it okay if I put my hand here when I'm, doing your breast exam? And again, there's this thread that goes through people who are survivors of trauma and sexual trauma, is that feeling out of control. And if you think about the personal, intimate nature of a GYN exam, and it's internal, they can't see what's going on, they really feel out of control. So our goal as healthcare providers is to avoid re-victimization and to put them in control as much as possible throughout their visit. So what can we do to make them feel more comfortable and safe? We want to be patient-centered. So what does that mean? Well, the patient's well-being is our first priority. So you want to communicate that. I'm here for you. I'm here to take care of you and meet your needs and what you see as a priority for yourself. You want to be a partner with them. You want to share power. You want to share decision-making as much as possible. You want to make her feel safe. And again, that's letting her know that she's in control and that I'm not going to do anything without your consent and without explaining what I'm doing. It's important to give her a choice of a support person. Like at the Y, when we do forensic exams, there's always a volunteer advocate there that they may choose to have in with the exam, or they may not. It's totally up to them if they want to have a friend or family member with them. But it's always important to talk to the patient one-on-one first, because obviously you don't want to have an abuser in the room with her, and you want to get a chance to get her concerns ahead of time. So what else can we do? Again, set expectations, explain exactly what's going to happen, and let her know that she's going to have a chance to stop or take a break if she needs to. And I think it's really important to be honest and don't downplay what this exam is really like. It's not a comfortable experience for anybody, so don't pretend it's not a big deal. And tell her you're going to try to be quick and gentle, but as thorough as possible. So here's just a little cartoon. I mean, we can all relate a little bit, right? I mean, who looks forward to one of these exams? Nobody. I mean, and like even with my own exam, I know what's going to happen. I know the relaxation techniques, and I still do the death grip on the table. And so telling someone to just relax really doesn't do the trick. So what can we do during the exam? First, reduce the power differential. Don't stand over her when you're conversing. How many people actually do exams? Anyone in the room? But does anybody work with people who do exams? Anyone? All right, well, you can bring this back. Hopefully you'll find a way to.
So people all over the world.
Okay, all right, oh, awesome, okay. So don't stand over her when you're conversing. What I do is I pull up a chair, like, next to her. She's on the table there, and I pull up like right next to her, not facing her. I won't bring my laptop in. I just have kind of a note about the HPI, the history of present illness, and I've already looked at her history, and so I have a little bit of idea of what's going on. Treat her like she's an expert on herself, because she is. She's where you're going to get your information from that you need to make clinical decisions. Do what you can to make the environment as comfortable as possible for her. So make sure your room temperature is comfortable. That the specs, if you're using metal specs, make sure they're on a heating pad or warmed. Do you guys know what I'm talking about when I say speculum, right? Okay. Gowns, use comfortable gowns or drapes for appropriate coverage. We put pictures on the ceiling as a distraction of something to look at besides the ceiling tiles. Ask her to predict what might be the most difficult part for her. Ask her how you might be able to make her more comfortable. Talk the patient through. You explain what you're going to do in advance as well as when you're going through. Unless the patient doesn't want you to. Most of the time they do, but occasionally you'll want a patient that she doesn't want you to talk to her, or she wants to do her own thing, and have a patient like sing or talk to herself through it. But most of the time, they want you to talk them and to them and tell them what you're doing and why you're doing it.